Welcome to Know Thy Shelf, the Emergency Medicine Edition. First, to introduce myself, my name is Dave. I am an emergency medicine resident hailing from the state of Pennsylvania, originally from the world's greatest state of New Jersey. I went to medical school down in Florida, and now I am a second-year EM resident, and I am here to help you through not only the craziest that is an emergency medicine rotation and shelf, but the added craziness of emergency medicine shelf clerkship during a pandemic. Oh my. So let's do this. So what we'll cover today, some study schedule tips, some resources, some mistakes to avoid. I'll talk a little bit about what an EM clerkship is like, because it's so much different than all the other standard clerkships. EM tends to be a very unique thing. And then a little bit about med school tutors, and then we'll have a live question and answer session so that you guys can ask me what incarnation is happening, how do I do this, and all sorts of stuff. So a little bit about who we are. We've been doing this for a long time. We love what we do. We're students, we're residents like me, we're attending, and we love working with students, with residents, with pre-meds, you name it. I really enjoy being here and doing what I do, and I find that it's rejuvenative and energizing because a quick blink of the eye, and I was in the same seat that you are, and a quick blink of the eye, you'll be in the same seat that I will be. We love working with our students, and we love seeing them succeed, and that's just a little bit, we'll talk more about later. That's just who we are. So first, jumping right in, the emergency medicine clerkship is so interesting because it's so heavily clinical. Anybody who's applying to EM knows about the standardized letter of evaluation, the SLO, the letter that determines pretty much your entire application. So nothing matters compared to the SLO itself. So let's jump right in, because you will be working with different residents. You'll be working with different attendings. Your job is to work with them well as part of the team and to work hard and see your patients. And these residents, these attendings, they're going to make or break your letter of evaluation. And they're going to be pretty much the way that you are evaluated. So, especially with your residents who you're going to spend lots of time with, introduce yourself, your name, your home school, where are you from. EM, like all the different specialties, has sort of stereotypes. And EM is known as a little bit more relaxed, which is good because usually most of the residents love working with the students. They love passing things down to them. They love being mentors. So find a couple and ask them questions, be nice to them, and they will help point you in the right direction. If you don't know a question and you're afraid of asking the attending, ask the resident first. A good resident, and most of them will have no problem helping put you in the right direction. So be proactive, see patients, ask good questions. And when I say good questions, it's make sure you're not asking the most basic things. So you shouldn't be asking what's the ratio of compressions to ventilations for CPR. You should know that. So a good rule is, have you tried doing a basic Google search for this answer? If it's chest pain, you should know what a troponin is and a little bit about it. Now, a good question would be, now that this troponin is negative and it's a high-risk patient, what time period would you want to do a second troponin? Would you want to wait 2 hours, 3 hours? So a good question is one that shows that you know a little bit of the basic science. Again, you're not expected to know anything. You're still med student. But you're expected to know a little bit about the basic science. And then a good question builds off that, shows you know the basics, and asks something thoughtfully. Be present for your resuscitations and for your procedures. Now, as a med student, you're probably just going to get mostly laceration repairs as your procedures. it's somewhat unusual that you would get something more complex like a central line or an intubation. Although occasionally you will get those opportunities. And if you do, don't worry about how well you do it. No one expects you to be competent at a central line or an intubation as a med student. You want to be competent at your laceration repairs. That is an opportunity for you to show some basic technical skill to your superiors. And then for the resuscitations, always be there. You want to score style points on your resuscitations, be there and ready the airway equipment. That's what I've noticed. So make sure your room has everything it needs. So make sure your suction is ready, make sure your bag valve mask is ready, make sure whatever crash cart or code cart there is available. So preparation is everything in emergency medicine. So if you show that you're at least taking the steps and say them out loud, if you're doing the right thing, get the points for it. If somebody's coming in 10 minutes and they're in cardiac arrest, tell it to yourself, all right, the suction is over here, the bag mask is over here, the ventilator's over here, we have the respiratory tech here. Say it out loud. It doesn't need to be perfect. And the process is important. As far as other things you're going to do during your clerkship to differentiate yourself and to show you're interested, ultrasound often. You can't really hurt anyone with ultrasound, so attendings are going to let you go wild with the exception of you will probably not do transvaginal probes. You could ultrasound the gallbladder, do fast exams, do eyeballs, do all sorts of goofy ultrasound stuff. Because again, you can do an infinite amount and it always shows you're trying to do more. So do ultrasound, ask questions, and then reevaluate often. Make sure you're not just doing H&Ps. A monkey can be trained to do H&P. You need to interpret, you need to manage, and you need to disposition. So a good high-level skill for your clerkship is learning when to come bother the attending or the resident with results. So don't go to them with every small thing. Try and stagger the times you come to them. Show them that you're capable of some basic independent management. If it's an asthma patient, do all the right things. Order the steroids, order the Decadron, order the albuterol nebulizers, and then go see them after 20 minutes after their first nebulizer is up. And then go see them again. And then after a little while, communicate with your team that their lungs sound better or they don't, or interval changes. And then, again, put time into the small things. Get the patient story. Because you're a med student, you're going to be given exhaustingly long presentations that you will never give for the rest of your career. And you'll be expected to know things that really don't matter. But you need to know it, otherwise you'll get points docked off for it. Be up to date with resulting labs. The worst thing you could do as a med student, because you're only going to see 2 or 3 people at a time, is to miss that the troponin came back positive. Oh, ooh, that resulted 10 minutes ago. Oh boy. Now granted, if you're doing other things, you're not expected to be omniscient. But if you're sitting at the desk, you should know everything within a couple minutes that's new. And then you want to get a lot of good style points. Perform a chart review that supplements your H&P and management. You will become an instant favorite. And again, this is a skill that you can do as a med student that doesn't require any advanced training to be as resident. So if it is an asthma patient, have they been hospitalized before? Have they ever been intubated before? If this is a chest pain patient, when's their last echocardiogram? Have they ever had a stress test? Have they ever been catheterized? Who is their cardiologist? So those gritty details will separate you and show that you're thinking thoughtfully about your management decisions. And then be there for moments. You have more time than I do, and I have more time than my attending does, and so it sort of goes downhill. When something bad happens, be there and stay there for the moment. Today, I had a unfortunate case of a young infant who passed away, and we stayed there for the moment, but then I had 7 more patients I had to see. So when you're a med student and something bad happens, and bad things happen in emergency medicine all the time, you have those extra moments to stay with the family. And attendings and residents really notice when you make the effort to be there for not just bad moments. Bad moments happen every day, but good moments happen occasionally too. So be there for those moments, share those moments, and you will benefit. So a day in the life, the best thing about emergency medicine is the shift work. Your shifts will likely be either 8, 9, 10, or 12. Your shift length will determine your pace, as this says. You can't push yourself with an 8-hour pace for 12 hours. You will burn out, you will trail off, and then you'll start to make mistakes. Pace yourself if it's a 12-hour shift, especially if you're assigned with one attending over 12 hours. They're not going to expect you to sprint for 12 hours. It's impossible. However, push yourself, but know where your limits are. You should be trying to see 2 or 3 patients at a time by the end. You're not going to be expected to see 4 or 5. 4 or 5 is where interns sort of start after a couple months. If you have your 2 or if you have your 3, know them down cold and know their next steps and know all the little nitty-gritty details about them. Know about decision rules and scoring systems. That's very big in emergency medicine. It's very big in anything. The research and all the scoring tools and whatnot. But they're very important in EM because we make all these decisions on the fly. So know about your well score, your PERC criteria, your heart score, if you're pediatrics, asthma scores, all sorts of things, your different clinical decision tools, your PCARN for pediatric head trauma. Because again, that shows that you can do basic management. Again, you're not going to be expected to be perfect. If you heart score someone a 4 and it's really a 3, nobody is going to yell at you. They're just going to say, well, I would say this is this and this is why. And then again, can you interpret, manage, and disposition? That's the biggest thing. Anyone can do a history and physical. Can you do it correctly and then do it with multiple patients? Can you see 2 or 3 and can you manage them and do the things that you need to do? So ED pearls, and then we'll start talking a little bit more about shelf stuff. Again, learn your residents and your attendings and tailor your interactions between them. Some are very strict and very academic. If you're on a clerkship, you're probably going to be put preferentially with these attendings. So be everything by the book there. So be very bland with your personality in the beginning. Be kind, be personable, but be bland until you can read your attending. And then open up more as you get to know them. Some are more relaxed, but still maintain professionalism. But you'll know right away if this is the sort of resident that, like, if you have a stupid question, they're going to be fine with it. And again, just be respectful, be professional, and you'll not go wrong. But at the same time, EM can be kind of cliquey. Now everything can be kind of cliquey. So be present, but like don't try and be overly familiar as well. Let them sort of, again, so many of us are just nice, chill people. We will welcome you into our little circle. If it's didactics and there's lunch to be had, we will tell you to come along with us. Now, obviously you can ask and that's fine, but it's always best to like be kind, be bland, and then open up and let the residents sort of accept you at their own pace. And this is a little bit from Gomer blog. So again, why EM? Because it is the best, most bad ace specialty out there. Gomer blog did all the specialties as Harry Potter's characters, and who got Harry Potter but EM? So let's be honest, it's the best of them all. So, and now a little bit more about the actual studying part. You will have free time. Again, people do EM because they want to have work and a life. Then that's something that you can't do if you're doing a surgery clerkship or surgery residency or an OBGYN clerkship or residency. You will have a little bit of free time in emergency medicine versus some of these other clerkships. I did two rotations as a 4th year. one at Lehigh Valley in Pennsylvania, and then one in Buffalo, New York. And my Buffalo rotation, I think I was on for 16 days. I was off for 12, which is almost 1-to-1. So you will have free time. And that means you've got to be diligent to make sure you're getting better, because you have free time in emergency medicine. You'll be expected to get better along the way. And then for the exam portion of it, EM is unusual. They have two different types of exam. They have the garden variety NBME, which looks like every other NBME out there, except it's a little smorgasbord of surgery, a little smorgasbord of OB, of peds, anything. Because remember that step 2 and step 1, half the questions start with patient comes to the clinic, half the questions start with patient comes to the ED. So just transplant half of those questions that come to the ED, and ta-da, you've got your EM MBME. And they also have an SAEM, which is Society for Academic Emergency Medicine. That was the test that I happened to take at my rotation. Make sure you know which one you're taking, and then take the practice for that. So there's practice MBMEs for EM, and there's practice questions for the SAE exam as well. So the content is not likely to be overly different, but the formatting is slightly different. And then prioritize things that help you actively learn. Always things like questions is number one. I was always a heretic for saying that I think first aid and reading first aid is a little overrated. So don't come at me. But practice questions, flashcards, studying with friends, active studying is much better than passive studying. The good rule of thumb is if you can get it wrong, it's active. You can get a practice question wrong, you can get a flashcard question wrong. Can you read first aid wrong? Probably. So start early, start often, try and get a good pace in. Again, most EM clerkships have a decent amount of time off. So make sure you're sleeping. Make sure you're getting your work in on your days off. And this question that's sort of posed here, study strategies that work for step 2 and these sort of clerkship shelves that don't work for step 1. And that is something that won't work for like clerkship or step 2 is trying to sort of outwork the exam, because you need to know a little bit about like the research behind these major algorithms. You need to understand the gestalt. In step 1, if a patient had a disease, they had all 9 symptoms of 9, and it was a layup. And it's just, did you recognize whether this was, lung cancer? Did you recognize all of them or enough of them? But like step 2 in these shelves, they give you some ambiguous patients sometimes. Now, chest pain is not always an MI. It may be all these different things, or it may be nothing at all. It may just be something like costochondritis. So be very careful that you take the entire vignette and gestalt into account, because unlike step 1, they're tricky. Is that slightly low hemoglobin of 11, does it mean anything, or is it just a red herring? Because there's plenty of just abnormal lab exams in real life that I don't even think twice about. So find some pockets to study. And we got a question here from Gregory. Any recommended pocket resources? So yes, entirely. There's a bunch of good resources out there. There's SAEM, there's ACEP, and there's EMRA. EMRA, I found, has great pocket resources. They have all the little guides and books that comes with the membership. Things that I would carry with me would be the EMRA antibiotic book. So, or you can get it on an app on your phone. Now, when you're a med student, unless you have a tablet, I would just use the paper copy, because you don't want anybody to think you're on your phone, even if you're looking something up. Now, if it's on your phone and you're telling your attending you're looking it up on there, that's fine. But I just wouldn't even chance it. The tablet is a little easier to get away with, because you're assuming you're doing something productive on a tablet. It's not necessarily the case with a phone. But like the EMRA antibiotic book is a big one, because you should know your basic antibiotics, your Vanc, your Zosins, and all that stuff. But if it's something unusual, or if it's a dosage or a timing thing, look it up. Your attendings look it up too sometimes. It is okay, especially if, like, what if there's an allergy or something weird going on? So the EMRA books, which is Emergency Medicine Residency Association, they can be found online. They are very good. There's a pediatric one. There's like a resuscitation one. There's stuff that I would have in my pocket if possible. And little cards on your ID badge I found is helpful as well. I have and I get those off Amazon. A pediatric card is super helpful. What are normal vital signs for this age group? I don't know. I have no clue. And I always because I just don't work with kids every day all the time. So I flip up and I go, oh, wait a minute. That 120 is normocarding because they're this age. And now I don't have to worry. So that's helpful. Ultrasound numbers are super helpful. How big is the appendix supposed to be in ultrasound? How big is the gallbladder supposed to be before it's too big? They're good. You want to make sure you know as much of this as possible by memory, but it's good to have those guides available. If you're starting propofol or giving ketamine, what are the dosages? It's good to have that available, especially if you're about to do a resuscitation and someone's coming in for like a code or something like that. Oh boy, what's the dose of etomidate again? Especially for peds, because that is so weight-based dependent. So yeah, find your pockets of time to study. Typically the ER doesn't have a lot of time for you to study on shift unless you're doing overnights or early mornings. Bring something anyway. If it is dead, completely dead, like no patients to see, just do a couple practice questions at your leisure. Just show that you're doing something productive. Don't go on your phone. It's 1 month because ACEP's new policy is do one rotation and one rotation only because of COVID. This is it. You get one shot at it. Don't even bring your phone or put it in your backpack or whatever you're bringing with you. Bring something for the pockets of time. Try this number 2. This is a big one right here. This is how you're going to learn and how you're going to remember. Once you see it and once you do it, you'll never forget. With all the numbers, especially, I'm just not great at memorizing the numbers. PPI doses for upper GI bleeds, oh boy, they're numbers until it's a real person with an upper GI bleed that needs a 80 milligram per kilogram bolus, followed by an 8 milligram per kg per hour infusion after that. So the numbers and the details become real when you link them to real people. Always stay connected to those who provide your support and accountability. Know and ask who are the people that can be helpful here. There's always someone at a residency. There's like whether a resident or whether it's the clerkship director, who's someone that you can lean on. Keep an eye out for institution-specific resources. If there's something neat there, do it. And then again, too many can be problematic as too few, so we'll jump into the actual resources right here. The main ones that I've seen in terms of questions, case files, EM, is pretty popular. Rosh review is the gold standard as far as emergency medicine questions. SAEM has practice questions. There's a gazillion little Q banks out there now. EM Coach is one of the new ones. PEER, PEER, review is another one. Especially in the beginning, I would stick to something like case files or SAEM because they're going to be more on your level. Rosh review and some of the other ones, again, they're not bad, but they may have details that are above what you're going to do. You don't yet need to know this sort of technical nitty-gritty things of like certain procedures that are done when you're a resident, and they'll test you on that. You'll be like, and toxicology. You're just going to know no toxicology besides the basic cholinergic overdose, anticholinergic, the stuff. If it's not on step 2, you're not going to know the toxicology for it. So, and a lot of the Rosh review and these residency banks, the question banks, are going to have more advanced things. So start with something like the SAEM questions, your NBME practice tests, for practice questions. For as far as website goes, man, there is so much I could fit multiple slides on this. Core DM is a great place to start. Council of Residency Directors of Emergency Medicine. WikiEM is my personal favorite. It's basically Wikipedia for emergency medicine, but it's not like literal Wikipedia. It's great because if there's something I don't see often, or it's kind of weird, I'll look it up and it splits it into, what's the important questions, what's the management, what's the disposition, what are the treatments. If I'm ever unsure, WikiEM is usually the first place I go just to make sure that I'm not missing something silly. Life in the Fast Lane is incredible too. This is a kind of combination EM, EMS, ICU sort of website that has all sorts of great stuff for EKGs and all sorts of good material. Again, there's a gazillion of them. The EM is just dominated by podcasts. There's too many. I don't do a ton of podcasts unless it's a targeted thing, just because there's too much, and it's a good problem to have. But like the last slide said, too much can be so problematic. You want to find a couple things that work and just stick to it. EM Fundamentals is a great site that I use fourth year that really break down the basic workups for its most common complaints. Rebel EM is another good one. It goes on and on. And then there's some good resources. There's an emergency medicine clerkship primer that a lot of different schools put up. I can think Western Michigan does a great job putting up sort of resources. Search out a lot of these things. Again, Core DM does a tremendous job because they have basically outlines for all the major presentations for third years and for fourth years. So, and it's real good stuff. So ask your residents, ask your attendings, what worked for you or what did you use? Try some different things, figure out what works, put together a system. So EM study tips here. So for emergency medicine, you have a philosophical shift from preclinical to clinical years. They don't really care a lot about the basic sciences. The mitochondria is the powerhouse of the cell, oh boy. But EM is a super clinical field. You will get your academics for sure who are real into the basic sciences of this and that, but they tend to be fewer and a little more far between. No, EM is just so clinical. Be good at clinics, and I mean you're going to get quote unquote pimped on the basic sciences because you're a med student, and you should still know them, but you're not gonna see nitty gritty details like you would in internal medicine rotation, because EM is a little good at everything instead of being amazing at one thing. And then again, it's all workups and resuscitations. It's all stuff like that. How do you tell if something is if someone is super sick or they're fine? So those are the skills you want to see. Sick, not sick. Is this guy who vomited once, is he fine? That he does vomit once and he looks good and you can probably just treat him symptomatically and his belly is soft? Or is this someone who's peritoneal and super sick and requires a whole septic workup with antibiotics and fluids? That should be your goal in fourth year. Sick, not sick. And where the real struggle begins is someone who's sort of sick-ish or something in the spec. And you're not going to be expected to be good at that. That takes years to sort of differentiate. It's easy when someone comes in with cardiac arrest. Oh, let's do CPR. Or it's easy when someone comes in just for a lac repair that is otherwise fine. But those in between, the classic pregnant patient who syncopized or pre-syncopized. Oh goodness, what do we do? How do we work them up? Those are hard. The back pain that may have sort of an alarm symptom, but it's not really an alarm symptom, but it's new and it's weird. What do I do? How do I treat that? And then management and disposition, that's where you're going to get all your extra points. Know your managements, reevaluate, know your dispositions, know your algorithms, and then defend your decisions. You're going to be wrong probably most of the time, but just defend why you thought that way. If you don't think they need a CAT scan, and you could say, I don't think they need a CAT scan. This car accident was low speed. They're 24, and I can use the Canadian head CT rule, and they're negative by Canadian. I don't think they need a CAT scan. Boom, you've done it. Their attending may say, yeah, I want it anyway. And that's real. That's just life. But when you say something, have a rationale why, defend it, and work on your workups. You're trying to see the same thing as many times as possible. Your chest pain, your shortness of breath, your weak and dizzy. Those are particularly hard. Your pre and syncope, your belly pain, your altered mental status, your fever, your cough. Now with COVID, what is COVID? What gets a swab? What doesn't get a swab? It's real easy when they come in hacking up a lung, there's fever 102, and they work in a nursing home. But like, what if they have some mild headaches and just a dry cough and they're 25? Do you need to swab them? Do you need to get the rapid swab? What does your institution have? What are their policies? It gets real complex really quick. So work on your workups and try and develop a basic framework for them. And then again, maximize your, like if you can use UWorld as well, because UWorld is kind of emergency medicine. So like maximize it, maximize your flashcards, whatever questions you're doing, make them into flashcards. If you have a number that just won't stick, make it a flashcard. Quiz yourself and know all the basics. Know all the toxidromes that are important. They love to talk about the toxidromes to med students in terms of like the anticholinergics, the cholinergic crisis, the sympathomimetics. That's a big, big stuff. So make sure you supplement and make your learning efficient by using flashcards from the things you get wrong, the things that you need to memorize. Again, case files is a great resource. Emergency medicine, it's a great way. If case files works for you, I know some people love it, some people hate it, some people in between. If it works for you, you will be very happy with the way the emergency medicine one is done. Again, all different things. Try and pick a couple things that work for you and stick to it. EM is saturated with so many good things, so many good podcasts, so many good websites. So have your first line resource, your second line resource, your third line resource. If I have a question and it's a management one, WikiEM is my number one place to go. And if that doesn't answer it, well, Trusty UpToDate will help it. And if that doesn't work, well, now I'm off into the web to see, does RevelEM have something good? Are there other things that are helpful? So one at a time, develop your style, and everyone's going to have their opinion. So try and get if you ask 10 people how to study for emergency medicine, you're going to get 10 answers. So find a couple resources that work for you. Other resources as well, PreTest, NBME, AMBOSS, Firecracker has an emergency medicine clerkship collection of stuff. NBME has emergency medicine forums. Even if you're doing the SAE exam, I would still probably do it. Again, because of COVID, everybody gets one rotation, so it's not like you're going to save it for something. So take it, do it, you will get there. So speaking of, you will get there. Closing advice, stay positive. You've made it this far. Some days are going to stink. You're just going to be wrong. And I mean, even when you're an intern, I remember being wrong about almost everything for the first 6 months. Oh, that gets old. And you're like, man, I know nothing. Keep it simple. Try and do the best you can. Again, latch on to those who are going to be very relaxed and very open. Those people are super helpful. They're going to teach you. They're going to help you. What's it called? You can do it. There is that light at the end of the tunnel. One day at a time, one shift at a time, one patient at a time. If you're stuck with a particularly unsavory or unhelpful attending, just grit your teeth, tough it out. I've been there. I've had some great attending, some I could give or take, and some bad attendings. So try and learn a little bit from each person. Even if what you learn from that attending or resident is, I don't want to be like them. I had a couple of them during my rotations. I don't want to be like them because they're rude to so-and-so, or I don't like the way they do this. And that is still a learning experience. So, but you'll find more positives than negatives, and be confident. Trust your training, trust your instincts, and run everything that's invasive in any sort of way by your residents, your attendings. Don't go off ordering MRIs on people because that could be bad. And then again, try and push yourself every day to do a little bit more, to know a little bit more. And also remember, it's a marathon. This month is a sprint, but emergency medicine is a marathon. Because you get one chance only, you're going to be sprinting for that month. So make sure you're well rested before it, well rested as possible during it. Don't trade sleep for trying to squeeze a little more out of you. You're going to try and borrow from Peter to pay Paul, but Paul charges interest. So, all the good wellness things that we talk about for all of our other parts of med school and medicine still apply here. And then, coming full circle to MST and what we do here. Again, we can do a little bit of everything from the very beginning of like step 2, step 3 tutoring, ERAS consulting. I really enjoy working with my students. I enjoy solving the problems, and you get to see the progress. That's always fun too. When someone has a little plateau, and then boom, they break through that plateau, and their next practice exam is 15 points up, and they're so excited. Or something that I talked about the day before, if it's a clerkship tutoring, all of a sudden they busted it out in the middle of their clerkship next day, and the resident or the attending was like, "Oh, that's interesting." And it's moments like that are going to help get you through it. Like I said, it's moments. Be there for the moments. Our job is to create moments and try and help you to get better and help you stay sane, because it does take a while. I'm about 14 months into residency, and I'm actually starting to enjoy it now because I'm not drooling on everything I see, because I actually know basic stuff now. So again, work hard, and you'll find it's more fun as you get more and you get better. You can do it. So this is our question and answer part of it. We have a question from Shemzi, who asks, what is a schedule for a resident in EM? How do you prevent burnout? The average for an intern is about 190 hours a month, which if I knew how to do math, and I should be able to, is about 47 hours a week while on ED, because 200 divided by 4 is 50, so that sounds about right. High 40s of clinical time, didactics usually once a week, something here, something there. It's about 50 hours and change a week of sort of expectation, which sounds like a lot until you realize your friends in surgery haven't slept for 2 months. So you will have time. Look at me tutoring while being a resident as well. So you'll have, how do you prevent burnout, which is the second half of your question, is find something that you love to do. I love working with med students still, and that's why I'm here. One of our other co-residents raises and breeds horses. Awesome. Another one is working in biotech, or they're doing biotech on the side, and is working on making COVID tests, as wild as that sounds. So another has 6 kids. He's super busy with all that too. So, you prevent burnout by using the time that you have and doing something constructive with it as well. So the schedules are not bad. There's hard rotations. There's trauma. That's the name of the beast. But you will have time, and you prevent burnout by staying close with your peers and by making sure that you're staying well. Anything else that would help a student that wants to go EM, stand out in the clerkship? Again, like that's why you're here. You want to stand out in this clerkship. Do your lacks and do them well. No. Try and take 2 or 3 patients. Show that you can manage 2 or 3 people at once. Know your management and dispositions. Try and ultrasound everything. Be present for your resuscitations and know your basic resuscitation prep. Again, you're not going to be expected to intubate on day 1, but know the things that you need for intubation. Know the medications and why you're choosing them. And then be there for the moments, help the families, call people for follow-up. This is all dependent on your institution, but like do the little things. If somebody comes in with like Crohn's-like symptoms and you're like, well, they're really fine, but like this is sort of funky and they're just in that right age range. Who gets these symptoms when they're 19 and they need to follow up with, digestive, with a gastroenterology? Try and help them get an appointment with gastroenterology. Now, if it's 2 a.m, don't wake up GI. Don't do that. But if it's like 2 p.m, and this is something your institution normally does, ask if you can reach out to GI and try and get them a follow-up. Or, do something, try and help connect those links between the ER and the outpatient world. Those things are things that you don't need advanced technical skills to do, that you can do as a med student. And just work hard. An old adage that was told from our school was, make it impossible for them to give you a bad grade. Make it so unequivocal that you did so well and you worked so hard that it would be unreasonable for someone to say you didn't do well. And you will be fine. Now, again, you might run into someone who just doesn't jive the way you do. But if you are busting your butt and you're working hard and you're improving, if you work with 10 people and one doesn't, particularly like you, those other 9 will drown that out. So, all right, this has been a pleasure. Welcome to emergency medicine. You all are going to do great at it. And if you have any questions, you're more than welcome to reach out to the office here. I am Dave. This has been Know Thy Shelf, and really Know Thy Clerkship for the field, the best field, if I may say so, and I do say so, of emergency medicine. Thank you for coming. Stay safe, everyone.